Hello everyone, this is Bob Rauner. Welcome to year 2 of the Nebraska Physicians Cancer Screening Initiative. We think our first year was very successful, and so we're doing a repeat for year 2. So timeline is very similar to last year. So March and April we'll collect our baseline data and start out the CME and Part 4 maintenance certification for everybody interested. You can do these Part 4 projects 2 years in a row and get credit for both years. So a lot of folks are going to do that again. June and July we'll do another mid-course data collection and then finalize again in November just like we did last year. So to do this, get the CME, you have to do two things. First, starting off with, is you have to complete this form very similar to last year. The difference is we have not set a target. Last year we had 65% as the target because we weren't sure where everybody was going to get to. Quite a few clinics have actually exceeded 65%. Our eventual goal is 80% by 2018. So it's up to you to pick, based on your baseline, what you think your target should be. So let's say if you're 66%, for example, you might set it at 76%, or you might go all the way to 80%. Again, you'll create a plan just like before. You'll put a few things in each thing. It can be the same thing you did last year if it was successful, but you can make some modifications. Some piece of homework you might say is that workflow diagram. Again, you can use last year's workflow diagram, but update it based on what you think works and what doesn't, and do make some modifications to that. Again, the context of this is 80% by 2018, meaning getting everybody to 2018 if we can on both colorectal and breast cancer screening. Last year, I'll be honest and say I wasn't sure that 80% was achievable for everybody. We actually have a couple clinics who are really darn close to this. So I do think it is possible to get a lot of clinics to 80% by 2018. We actually did have two clinics meet it for breast cancer screening. Some interesting notes is that there's not much correlation between size of the clinic and how well they did. We had some small clinics that are up near the top, and we have one of the biggest clinics up near the top. Also specialty, there are internal medicine, family medicine, and OB/GYN clinics within this top list, so it isn't necessarily confined to specialty. Although I do think, and there's some evidence out there, that Medicare patients tend to have higher screening rates than the rest of the world, so if you're an internist, that might give you a little bit of a bump. But actually, there, like I say, we got family medicine and OB/GYN up here as well, so there's not a real strong specialty link. Some observations from last year. Some clinics were good clinics to start with. They just had bad data. So this one, their stuff was in the wrong part of the chart, and Don hired his 15-year-old daughter to come in for $10 an hour and move the stuff to the right part of the chart. And lo and behold, they actually had really good numbers. After that, I don't think that it doesn't look like they made a lot of change in the second half. Some clinics made steady progress. Some clinics, even really big clinics, did well. This one happens to do really good with their annual wellness visit. More than half of their patients get in for that annual wellness visit, which is a perfect time for getting this done. So I think it again argues for the importance of making sure you're doing wellness visits on your patients if you can get them in. I think consistently across the board, the ones who made steady progress is because it was a group effort. Like I said before, we are having Ted Frazier from Great Plains Quality Improvement follow us along with Medicare claims data to see if we're doing better. We only have second quarter 2016 numbers, so only halfway through last year's project, but in the next few months we'll get a better update. Lincoln, Lancaster County, our goal in Lincoln was to be the best in the state, and we actually are there for colon cancer screening rates in Lincoln and Lancaster County. We'll see if some of the others improve as well, because we have clinics now across the state that are doing this. It's not just Lincoln. For breast cancer screening, like I mentioned, we actually have two clinics that are up in this range. They have exceeded the 80% target already, so that's great to see. And again, for Lincoln and Lancaster County, we're at a statistical dead heat between these three health department districts. So we'll see if we pull ahead this year or not. Again, quality improvement curriculum, just like last year, it's DMAIC. We're defining quality, and of course we're defining quality the same way, and we'll be going through the same process. So we'll kind of just summarize this since you've all done it once before, most of you. Again, an example of a German hospital system using DMAIC with the ultimate quality measure of dead, not dead, and it worked. So this is a good framework to use for healthcare quality improvement. Our definition is the same as last year. It's the NQF 2372 for breast and 34 colorectal cancer screening. That's the same as the MIPS measure. For those of you who are familiar with MACRA, it's the same for the Medicare Shared Savings Program. And it's also the same one used by Federally Qualified Health Center. They use something called UDS, so it's the same measure. So that's how we're defining quality. Colorectal cancer screening, what qualifies has not changed this last year. The U.S. Preventive Health Services hasn't made any more updates. They're still saying for the fecal occult to use that or the FIT testing. They still have not gone as far as DNA because of there's some confusion about what to do as far as follow-up testing for false positives. And so these are the recommended screenings right now. Mammography is just as controversial as it has been, with the USPSTF and AFP and ABIM or ACP recommending 50 to 74 in biennial screening, but Cancer Society and ACOG having slightly different recommendations. Again, some clinics have found some utility in having physician level or provider level comparisons, and I can work with your office if you want to create slides like this for your own office. So defining measure, once you've measured, now start figuring out what's going to work. I think one of the best things has been either alerts, reminders, or making sure that things are captured while rooming the patient. So again, that's why there's those wellness visits that's just something we do. We check for breast and colon cancer screening for every visit and trying to figure out how do you get as many patients in for the annual wellness visit as possible. That's a key success measure for all the ACOs that are achieving savings, is that at our conference in Washington, D.C. last year, that was one of the biggest things they said, is they make the percentage of patients that get in for an annual wellness visit one of their biggest quality measures for incentives for the physicians. So getting people in for that and then using that opportunity to make sure people are getting their screenings, and this doesn't just apply to this, but pneumovaxes, influenza vaccines, depression screening, everything can be done during that wellness visit. Communication, again, that's the other big thing. The clinics that get together, talk about it, review this on a regular basis, make it a positive competition. They're the ones who are doing the best over and over again. So once you've done that, we'll set your measures. I'll send you out the form for this to fill out. If you have any questions, let us know. When you complete this, you send it back to Mary Jo Gillespie, and she'll upload it into the IPMA system for your CME credit. A question that comes up frequently is, why don't I just give you the magic workflow diagram? And the answer is, it varies because every clinic has different kinds of staff, different strengths within their staff. They have different organizational structures within their clinic, and there are many different interventions you could try, some of which may work for your population but may work not. Some maybe do your electronic record program. Can it do a reminder system, or can it? So because the staff and interventions vary from clinic to clinic, it's really up to you to create your own workflow diagram. Also, the studies do show that a clinic that creates its own workflow does better. They create it, they own it, they know it works. As long as they have a good outcome and have some help, they usually do best by defining their own. So you, as a clinic, pick what of these various things that we're working on. There's some interesting things like working with people outside of your agency. People's Health Center here in town in Lincoln is actually going to be potentially working with the Malone Center and the El Centro de las Americas to work on some ethnic level improvements on Hispanic and African American population, for example. So working with outsiders, reaching out your clinic walls may be some helpful things. We are working with the American Cancer Society on this also, as well as our local health department. So then once you decide what your workflow diagram, you create it and then make it from there. So again, you should have something kind of like this. My favorite summary from last year was April Brinkhoff's clinic, where she sent a picture to me, and essentially it summarizes her project in 1 year with baseline, final, their 2 workflow diagrams, their summer numbers, and then how they finalized, and highlighting, of course, the people who did best. She has a great story in that her father was screened partly because of this project and had a precancerous polyp removed, so that added some buy-in. So congrats to April and their project. They were actually one of the better clinics on this, actually. Last year, we're going to try this. We had 27 clinics send data, 23 of whom completed the CME in Part 4. The ones who completed the CME in Part 4 are the blue dots, and the ones who did not are the yellow. So I think effort does tend to, surprise, have something to do with how well you do. So we're going to try and get everybody involved this year again. Lessons learned, again, I've used this slide repeatedly, but it is borne out over and over again that the clinics that do the best have a lead physician that takes it on, but delegates appropriately, and getting the staff to do things like standing orders, because sometimes the staff has a better role of actually making it happen than the physicians do. Number 2 is measure but keep it simple. Pick your couple things you're going to work on and do them well, and then move on to the next thing. Number 3 is getting everybody involved, not just the physicians, but the office manager, back office, front desk. Make sure everybody knows what their role is. The example I use is when that colon cancer screen, that colorectal or colonoscopy report gets to your clinic, it needs to be scanned in, noted for what it is, and the date put in. Otherwise, your system can't pull it out. So whoever scans in the reports needs to know why their role in the system. And lastly, getting people to meet together for planning time. Oftentimes, the clinics that have that small team of a lead physician, care coordinator, and office staff that meet on a weekly basis for various projects, and then a monthly staff or physician meetings where this is discussed, those are the clinics that do it best. So again, DMAIC is our quality improvement framework. If you have any questions, let me know. I'd be happy to come out to your clinic to talk, and also to talk about other topics like staffing for effective quality improvement and how not to use quality data. Now that people are moving into claims-based measures, there's some strengths and weaknesses there, and I can walk through some of those things if you have any interest. So thanks for participating again this year, and I think we have a very strong chance of having the best screening in the state and or country. So